could this be a health systems crisis and not just a health crisis? I'm talking about COVID-19. Is our healthcare system imploding? Well, my next guest says this is a health systems crisis. He's an epidemiologist, and thanks to him, I've had to practice that word so many times during COVID in order to be able to speak with him, because it's one of those words that just get me. He's also an associate professor at the Faculty of Health Sciences at, see, I can't say sciences, but I can say epidemiologist. Well done to me. Associate professor, Faculty of Health Sciences at University of Ottawa, and he's supposed to be taking care of his baby right now, but instead he's helping to take care of my new baby. Good morning, with Dahlia Kurtz. Dr. Raywat Deonandan, good morning, sir.
Good morning and congratulations. It's all very exciting.
Well, thank you very much, and I appreciate you being the first guest, and for being the first guest on Good Mornings. I'm giving you a great big bag of nothing, but you can do anything you want. Anything at all.
I have so much. I don't think I've got space in the house for a bag of nothing, but I'll find space just for you.
Thank you. It's a good thing I'm small, because if I'm going to fit in that bag. All right. Dr. Deonandan, I know that we're laughing right now, which is actually quite important to do during a very difficult time, but this is a very serious conversation, because also as of today, a lot of things have changed. This, people can hear us have this conversation from across North America, but this is something that could potentially affect people everywhere. Ontario, Canada, our healthcare system is imploding, isn't it?
Yeah, it's under great strain. And we as Canadians are often quite proud of our healthcare system because we compare it to, the worst versions of it. The Americans, for example, the American healthcare system isn't that bad depending upon who you are and whether you've got insurance. If you haven't got insurance, you're out of luck. In Canada, we have, of course, universal Medicare. Everybody has access, and we have guarantees for the portability of that access, et cetera, et cetera, et cetera. But it has its limits. And we look around the world, there are failures in our healthcare system having to do with things like waiting lists and capacity. So in terms of number of acute care beds per capita and number of ICU beds per capita, we're actually near the bottom or middle or bottom of the list of OECD countries. So amongst wealthy nations, our capacity for giving healthcare is actually not that great. And as a result, public health emergencies like this pandemic tend to stress us faster than it otherwise would and creates crises with a lesser amount of stress. So I'm not minimizing the crisis, not at all. Let me just say that first of all. I'm saying that looking forward, we have to be able to increase our bed capacity, increase our healthcare worker capacity, and be more nimble in how we can respond to threats like this.
We're under a lot of, or not we, I should look at our government. They're under a lot of scrutiny right now because the vaccine administration, but you also say that salvation doesn't necessarily lie in the vaccine, even though we have been extremely poor in executing its administration.
Yeah, so we could have got to something resembling normal earlier in this process. Of course, COVID zero is a popular phrase bandied about. I'm not sure we had political will for COVID zero, but that was always on the table. And that's not necessarily a healthcare capacity endeavor, but it would have certainly salvaged our healthcare capacity. But testing was our salvation early on. And I expected a year ago that that would be what our full court press would have been all about, is upgrade, accelerate our testing capacity, invest in rapid testing, deploy rapid testing in more creative and imaginative ways to get society up and running with controls. If you look around the world, places like East Asia, Taiwan, South Korea, Japan, that never went into much of a lockdown, if any at all, they control the pandemic through testing and contact tracing and vigilance. We always had that option. And I don't understand why we didn't pursue it more vigor. So we have the skill set. We had the map for what to do, and somehow we lost the will to do so, and it's quite confusing to me. Now, where we are now in the pandemic, we can see the finish line, and we see South of the border, the United States vaccinating at enormous scale. California has a date for reopening. I think June 15th is their date. So we think that is our path as well. And that probably is going to be our path because I don't think we have time or political will or public tolerance to acquire, testing capacity or go for COVID zero. So vaccination now remains our best and probably our only path to fast normality. How's that for a depressing conversation in the morning?
Let's talk about how great Iceland has been. let's increase their immigration right now. So Dr. Raywat Deonandan is an epidemiologist. He's with us right now on the first episode of Good Mornings with Dahlia Kurtz. It's so weird to talk about myself in third person. I should have you announce what the name of the show is. But you talk about the Icelandic approach to COVID-19, and you like that one. Why?
Well, I did originally. And they've done a very good job first off, right out of the gate. They used testing to great effect. They did proactive testing. So what much of the Western world does is passive surveillance. So surveillance is a scary word that scares a lot of people because it sounds like Big Brother is watching you. But in epidemiology, surveillance just means looking out for incidents of disease so we know where to direct our resources. And there are two kinds of surveillance, really. There's passive and active. Passive is when people come to us with symptoms and we test them. And we assume that's how much of the disease we have. But active surveillance is when we go out and hunt down the disease by testing asymptomatic people, by going to where neighborhoods where perhaps signals don't exist and doing random testing. We do a little bit of that now with the wastewater surveillance in places like Ottawa. But Iceland early on was doing that. In fact, they partnered with a private company, Decode, I think it was, to do private testing for anybody who wanted it, paid for by the government. And as a result, they had a really good idea of their COVID burden early on and were able to direct resources accordingly. As a result, they had two waves. The second wave was in October, and since then they've had almost not no cases, but certainly a manageable number of cases. In fact, they have an average of 5 cases per day now, with no spike in deaths since about October as well. So their approach has been effective to my mind, and of course now they're vaccinating as well, so they'll be out of this fast. Looking around the world, there's a variety of approaches we could have taken. Uruguay, poor Uruguay that no one ever talks about, a low-income country. Early on, they invested in domestic manufacturing of tests. And as a result, they were able to use testing to great effect and keep their numbers quite low as well. Bhutan has had 0 deaths. Maybe they've had 1 death now, but 0 deaths throughout the entire pandemic. And that is in large part because early on, they reacted fast. They put public health top of the agenda. They invested in testing and a lot of contact tracing. I mean, the first case they detected was an American tourist, I think it was, and they wrapped that person around a lot of testing. So they're...
What's amazing for you right now, Dr. Deonandan, I see a future with transitional skills. You could actually work on the tourism board for these countries and get more people. You could raise the revenue for these countries. I have one last question for you before we let you go. I know that you find germs really gross. The way that I look at feet. Feet are just like big germs unless you're under 3 and they're adorable and I want to eat them even though I'm a vegetarian, but we won't get into that.
So am I.
I want to know, what precautions do you take during COVID-19 that you don't think other people may be taking? The precautions you take not because of your neuroses, but because you're an epidemiologist.
I avoid unnecessary contact with people. Like, I go outside for walks and exercise. I say hello to my neighbors and have conversations with people from a very safe distance. If I don't have to go into a place, I don't go into a place. We order our groceries online. We pick them up at curbside. We never go into stores unless absolutely necessary. So I don't think a lot of people are...
Do they pick mushy apples for you, or do you get like...
Oh, that's a good question. So far, we've been pretty lucky with the good apples. But if you have options to not go into indoor environments, do not go into indoor environments. This will keep you more safe than otherwise.
Thank you so much for taking your time to join us. I'm sorry to your baby that you had to give my baby time today, but if people want to learn more about your work, follow you on Twitter, get some good education on things that they should avoid and how to get the right apples from their grocery store delivery, how can they find you, sir?
Well, my Twitter account is at my last name, which is Deonandan, Deonandan.
Yeah, better just to take the time spelling it than saying it for people, because they're going to spell. They're just going to put the alphabet alphabet in there. Just like toss in your entire keyboard and you're eventually going to find Dr. Raywat Deonandan, epidemiologist, associate professor, faculty of health sciences at the UNC. I couldn't say scientist again, but I said epidemiologist. Thank you so much for joining us today, sir.
It's my pleasure. Thank you so much.
I'm Dahlia. Coming up.